Hi everyone, my name is Dr. Girija Chetty. I am from University of Canberra Health Research Institute, and my presentation today is on machine learning, how machine learning techniques can be used for reducing medical errors in the context of nursing handover. Um, I am in UCHRI, and our team comprises of Professor Rachel Davey in UCHRI, and the rest of the research team is Dr. Leif Hanlon from NICTA, Robert Fan, and Mark Liu, our PhD scholars. I would like to briefly introduce the plan for the presentation. I would like to introduce the topic and give the background behind this and significance and motivation behind this work, and then try to address what are the questions formulated in the context of this talk, aims and objectives designed to address the work, and approach and methodology I'm trying to use on some of the experimental work and outcomes we achieved, and then conclude the paper. Now, the work is related to the issue of addressing medical errors in nursing handover notes, and this is due to the fact that there is a lot of proliferation of errors in the clinical handover system, because currently it is being currently the system involves taking the notes written on handwritten notes, and then when the shift is finished, the new nursing shift happens or starts, it is possible that a lot of information has not been communicated between one shift to another shift. So this normally happens when those who are really at the early stage of the careers in terms of physician careers, poor communications, and sometimes patient actions, like you can't communicate with some patients, that leaves very difficult to actually note down what happened in the clinical context. What we propose here is computer-based support system where you write algorithms. These are called machine learning algorithms, and they turned out to be a powerful technology to make the computer understand the meaning within the text nodes, extract hidden information, complex data in terms of text snippets within the text nodes, and try to build predictive models. So what happens is any missing information, any incorrect or ambiguous information is addressed by appropriate modeling offline and then training the system. So there is an urgent need for this kind of work, because in the clinical context, a lot of health is connected. Health data is collected every day. It's called big health data, and what happens is big in terms of not just the large size of number of patients, but the variety of data. You have got radiological scans, and then clinical information, demographic information, and then continuous temporal, the devices that are connected to the patient for monitoring are there continuously, the data getting captured. So there is what is called as 4 V's of big data: velocity, volume, veracity, and variety. This makes it actually computer systems to make sense out of this data a bit tough. So what we need is a kind of a proper modeling approaches drawn from the mathematical and statistical modeling techniques. So there are some work motivated by the statistical modeling that has happened, but they don't quite really address the need of the extracting information in the nursing context, because the data is not clean. There is a lot of missing information, there's a lot of medical jargon, and then that makes the computers based systems very hard to correct the errors and fix the errors, so that what you have is a clean information that is getting interpreted by the computer. Now, so what we need is an automated system which can take the data or the notes from the bedside straight in the from a speech recognition, like a dragon speaking system, or really take the handwritten notes, but you can just turn your iPad or an iPhone, if you have in that shift, they can just dictate or read the notes, and then it gets recorded in the system, and then that gets converted into text, and then it is also helps in automatically filling the forms. For these, when it's done, the form filling is done, the discharge summaries or the record keeping can be automatically archived, maintained. These records can be archived and maintained, and when the discharge happens, the discharge summaries can be prepared. So for this kind of automated chain, right from dictating the handover in each shift, and then to filling up the forms and storing the data at each stage, requires what is called as name entity recognition, and that involves machine learning techniques. So far there have been several approaches in other areas for machine learning, but machine learning techniques mostly work by what you call as supervised techniques, which requires labeled data. In nursing handover context, it's very hard to extract labeled data, because every nurse has a different style of speaking. This is basically extracting meaning from the text. Computer has to understand the text, and that is not quite easy to have it labeled data or a model from which it can be taught, the computer can be taught. So the handover notes in clinical domain are filled with lots of errors, medical errors, due to several reasons. And if one improvement that can happen in the clinical environment is if you automate the chain of nursing handover process as such. From some of the earlier incidents we have found, the work has got a lot of significance, because there are a lot of statistical data available on how can this impact on the patient safety. In Australia itself, you have 4,500 patients deaths caused by medical errors, and around 16.6% hospital admissions associated with adverse events, according to the data from Australian Institute of Health and Welfare. Likewise, it is equally a significant issue. In US, avoidable deaths from medical errors has been between 44,000 to 98,000 patients. In UK, 10% of the admissions are associated with adverse events. So the Australian this body, what it urges is improving the health data more effectively, and that requires interventions in terms of computer-based interventions or automated approaches, which can relieve I think nurses are very busy in the hospital environment, and it's very hard for them to find time to sit down and take notes after every shift about every patient. So if we can come up with approaches where computers can take over some of the part and then provide the decision support, which can then be making the whole process, and the nurses can actually devote more on the patients. However, the computers-based systems are not very good at detecting or understanding the text actually. So with the current machine learning approaches, the efficiency or the accuracy remains quite low. I mean, there's still errors. It's not fully that they can get the efficiency or accuracy as good as the humans can actually do it. This kind of approaches have found a lot of application in other areas such as speech and computer vision and speech recognition, but not the text-based data that's available in the nursing handover notes. There are a lot of professional development courses that's been happening to make this nurse taking the handover notes in a appropriate manner. But as we all know, nurses are quite busy and they have workloads are quite high. So it's the last thing one should expect in terms of that they try to write the summaries and the notes after every shift about every patient. So I think this requires different kind of steps or stages. First of all, have to find out what all is needed. You have to detect the errors in handover notes in terms of missing words. There's a lot of shorthand words, medical jargon, as I said, missing and incomplete. And then sometimes the new nurse or the new shift person is manually, it is not easy to detect some adverse events. Sometimes it could be possible, but sometimes it is not possible that some of the crucial information could have been missed out. And there is some hidden correlation and interaction between for a particular patient in terms of the symptoms they show, the drugs they are taking at that time, or the side effects that has happened in the past. You normally have the information about one shift or the previous shift or this time the patient was admitted in the hospital. If you have a computer, the computer could actually figure out the complete history in a few seconds and tell that last time when he was admitted, he probably one of the drug has had a side effect. And this kind of thing you don't have, I mean, doing it manually, and when you have all fully stressed in a hospital environment, this is from nurses' angle, it is pretty tough to do manually, or a person cannot do it as efficiently as compared to a computer assistant if you have. Further, the user-centric aspects also needs to be improved. As I said, if you just scribble the notes in handover, which is what happens in the handover domain, you normally have to manually sit down in front of the computer and write down each thing. This is what nurses probably do after their shift. But if you have this kind of the same system, can improve the user-centric aspects in terms of filling the automated forms, can be filled different forms which are needed for every shift. You fill up in a form, and then that removes, when there is no human in the loop, it actually, there is a less manual handling, and then less medical errors will creep in. This is what ideally should work like, but as I said, computer-based systems still far from being able to achieve the same level of efficiency as humans. So what is needed is coming up with better machine learning techniques, or techniques which will teach the machine how to understand text, how to make sense out of text, how to extract critical information, and how to fill the forms automatically, and or just create reports, automatic report creation. So the aim of the overall objective with the SIS background and the significance and how important it is to improve the quality of health data and reduce the medical errors and enhance the patient safety by doing computer-based machine learning approaches. And for this, as I mentioned, the earlier existing approaches have several shortcomings. We need to evaluate it and come up with several new machine learning approaches based on the different type of text nodes that's being used or that has been studied. And then evaluate with certain objective measures in terms of how much errors has been reduced and what was the level of benefit achieved. And then there is not much theory available on how this can be done, so we have to learn from the data. So having the data and building the models from the data, unlike the other qualitative techniques used in using human studies, here what you have is a data collection. The data could be qualitative connection, interviews, or a questionnaire type data, or clinical samples, clinical data that's been the parameters that has been collected for each patient. Then you build a model which can result in better transcribing or converting of the text notes into electronic entities, identify the different personal information called protected health indicators, PHIs, and non-personal information in terms of clinical symptoms and the drugs being administered, and then side effects, and the doctors and the procedures conducted, the test results. All this, if it can actually catalog it in terms of automatically detecting and filling up the form, you have a better outcomes in terms of patient safety and quality of care. The computational framework needed or we developed is taking the erroneous clinical notes, using natural language processing techniques, which actually tries to extract some segments of information, and then from that segments, information extraction means even in presence of missing and incorrect and lack of information, it can still work with a good efficiency and build the training models to extract the data, structured information from unstructured information. For example, one of the clinical name entity recognition process could be finding the location, name of people, and different biomedical terms in the sample handover text. So we use different type of data sets, and we are currently working still on several other aspects of this work. One of them is a synthetic nursing handover data set, and this is an open source data set available from our collaborator, the NICTA Machine Learning Laboratory, and then several other open source data sets which contain the text notes, and they contain, normally most of the clinical notes contain several benchmark information in terms of UMLS semantic groups. It contains information regarding the anatomy, like body parts, the chemical and drugs used, and then devices and disorders, geographic areas, living being, objects, phenomena, physiology, and procedures. So any piece of text which is unstructured, if we can make the machine to detect these parts and segment it, that will actually be very handy for making sense of what's happening in a particular patient scenario. For this kind of what we have to do is used in NLP tools, natural language processing tools, and open source machine learning based name entity recognitions. We have actually developed a couple of new algorithms. One is called as Maxend name entity recognition. Is drawn from the computational linguistics area, and then try to build the models where you give this sample data. We collected the sample data from a trained nurse. It was a synthetic data set, so we tried to actually get the nurse to model the scenario of handover and collect different, speak different sentences corresponding to the handover context, and for a different kind of wards like cardiovascular ward and pediatric ward, gynec ward, this kind of different environment. And normally what are the situations that happens with the patients. We try to each department, in each clinical department, we collected about 100 text notes, short text note that is typical of a handover scenario, and then she actually is a non-native English language speaking nurse, Filipino nurse, and then and she speaks in a computer that gets recorded, and then what we do is we do an automatic speech recognition, and after the speech is converted to text, from the text you extract these clinical entities in terms of these UMLS semantic groups, and after that we try to segment these and fill up the form and display the form for a physician to what happened in the previous physician or a next shift nurse who can actually see what happened. So this kind of note preparation or automatic report preparation is done once this whole thing happens. So we try to do different types of algorithms. One is Maxend, and this is what it looks like. I'm not going to go through. I have got only 15 minutes to speak, so I'm just probably going to finish off. But I have actually sent out the complete slides to one of your conference committee member, and probably you can extract these slides from them. Also, we have on Google Scholar, we have this paper, so if you want to go and check on this particular paper. So we participated in Clinical Lab Evaluation Forum Challenge, CLEF Challenge, where we were asked to actually come up with algorithms for recognizing the names and entities from the speech during the handover environment. So this is the kind of mathematical modeling involved. It's probably more interesting to people who work in the area of computer science, but otherwise it's not very interesting. But this is how we model. This is the architecture of the complete system, how we build the model from the data. This is the algorithms, and then we try to show that as this is the benchmark data and 4 different subsets of data we use, and these are the previous system's performance. The performance of the system is measured with an objective measures called precision recall and F measure. These are the standard challenge performance measures we were given, and these are the previous participating systems which have performed, and our algorithm based on Maxend, maximum entropy. has resulted in we have got better performance in each subset of data. Overall performance also is improved based on algorithm called maximum entropy machine learning algorithm. Further, this is the details of comparison with the previous participating systems. Then we tried also another algorithm which is motivated by probabilistic models called conditional random fields. While the previous one is a supervised learning, this one is semi-supervised learning, which means you don't need a lot of train data in the beginning, but then you need only small trained or labeled data, and then actually it bootstraps any new data continuously and iteratively learns, like how it happen in the children. Normally they don't have a lot of vocabulary in their mental models, but slowly they keep learning and iteratively their vocabulary increases, their understanding increases, and that's called as bootstrapping. And we can make the computers work like that by having a small labeled model and then continuously making it learn new text from a new context, and it will completely be able to interpret. This is based on probabilistic graphical models based on semi-supervised learning. And that's the architecture, and this is how we proceeded by iteratively training the model one after another. The algorithm, how does iterative training happens, is this is how it looks like. And the performance that is continuously, when we had very little training data and most of it's unlabeled and with no features, we got very low performance, but we kept on increasing the bootstrapped data, and then we found the performance increased significantly compared to the previous participating systems. Also our system is resulted in much better performance. These are the previous participating systems. So as you can see, this is our CRF is our model compared to the previous model who has been used other than conditional random fields for the same data set, but they use different machine learning algorithms and different features. So that's a comparison of how these two new models we compared, CRFs and Maxend, compare with each other. As we can see, the conditional random fields based on semi-supervised learning and that uses probabilistic modeling is much better than maximum entropy modeling. So we come up with two new techniques, but we are working further to improve these. I mean, ideally this should be 100%, but so far previous participating systems, as you can see, they haven't achieved that way overall. This is overall, and even the individual, they haven't achieved either so far. As I said, it's quite a complex task. So what we have come up is much better than what previous systems have done. Both our models are better, but the conditional random field model is much better than the Maxend model. So that's the actual modeling. But we want to develop that web-based system so that the nurse at the bedside uses a iPad or mobile phone which has an internet connection, which connects to the computer through the internet onto the central station or in some nursing station, and whatever she speaks, that gets transcribed and converted into the text and form filling happens. This is this kind of system involves a web client. This could be a iPad or an iPhone, and that is the real nursing station computer, where it runs a web service, and that web service connects to the different iPhones or mobile phones or iPads at the real hospital bedside, and any speech or any notes that is being taken in terms of dictating of the speech or writing down on the iPad, and then if you just press process, it gets converted and transmitted to this model. It could also displays on the local client. Also, it will be sent to the central station where it is attached to a bed number and the patient, and then it gets stored, and then a form gets filled, so a report gets generated. So that's kind of system we have developed. This is what it looks like. For instance, this is the text, and it actually transcribes and then extracts the important entities in terms of cell type, protein, DNA. The color coding says it has recognized in this piece of text different entities. Now these colored cells, like cell type, this recognized entities are then put into the reports, which the whole pipeline happens without human intervention automatically. So that's our initial efforts. There is a lot of work that we are working on improving this efficiency, and these are some of the references we are used. As you can see, you can just click on that and you can access these ones on the internet. And I'm happy to take any questions, or if you want, you can email me the questions. And I'm very thankful for your time, for listening to my presentation. Thank you very much.